Thanks, everyone. My name's Joy MacDonald. I'm the project lead for One Day, which is a fertility preservation service that we're offering nationally for all young children and young adults, for children and young adults who are preserving their fertility program with cancer. We are pleased to welcome our philanthropic partners today, My Room Children's Cancer Charity, and also Children's Cancer Foundation. In the early stages of this, we're in the early stages of this project that we actually commenced in January of this year, and we're in the early stages of naming and branding. And we're hoping to keep the name One Day, but we'll let you know if that changes. So at the moment, the name of this program is called One Day. To commence, I'd like to acknowledge the traditional custodians of the land from which I am speaking today, the Wurundjeri people of the Kulin Nation. I wish to acknowledge the traditional custodians of the various lands on which you all work today. I pay my respect to elders past, present, as well as community members who are participating in this meeting. I also acknowledge the significance of cultures, community connection, self-determination as protective factors for health and well-being of Aboriginal communities. I'd like to welcome our speaker today, Dr. Ginya Rosen. She's a Melbourne-trained gynaecologist and fertility specialist with a special interest in medical fertility preservation. Dr. Rosen is one of the medical leads for One Day and works clinically in our reproductive services unit here at the Women's, and is Deputy Director of our Fertility Preservation program as well. Dr. Rosen is also a clinical lecturer in the Department of Obstetrics and Gynaecology at the University of Melbourne, and she has recently completed her PhD in endometrial receptivity and uterine effects of cancer treatment. Once again, thank you very much. We've only got a half an hour, so we will make a start and hopefully we'll have 5 minutes at the end. Please put any questions that you might have in the chat and we'll try to answer them as we go. If we don't answer all these questions, we'll get back to you with some responses. So I'm going to hand over to Ginya.
Thank you so much, Joy, and thank you for being the project lead on this. It's, as you said, close to its inception, but already there's so much to do and things are well and truly underway. Thank you to everyone who's joined us today. Joy, can you move with the slides up a little bit? Yeah, that's it. So fertility preservation is something that's very close to my heart, to my work, and I really appreciate that so many of you feel that it's something important for you in your practice as well. We know that for young people who have survived cancer diagnosis, fertility is right up there in the first sort of top 3 issues of survivorship, and so this is something that we consider to be really important. It's, clinically, internationally, the guidelines tell us that it should be considered for everyone with cancer, at least a discussion or consideration of it. So it's no longer sort of an optional extra or add-on. And here at the Women's, we've really acknowledged that many, many years ago. In 1995, Kate Stern set up the Fertility Preservation Service, and since then, there's been a lot of work to take this field forward, and I would consider us to be leaders, probably not just in Australia, but also the world in fertility preservation research and practice. Right from its inception, also, we've had a strong partnership with the Royal Children's Hospital, and the Royal Women's have preserved tissue and also gametes for patients from the Royal Children's Hospital for many, many years. The trajectory of this program moved or changed slightly in 2019 when we started the National Ovarian and Testicular Tissue Transport Service with a philanthropic funding from Sony Foundation. We were able to, with the sort of criteria that they put for us, we were able to provide for people aged 13 to 30 access to ovarian and testicular tissue transport, as well as the processing of tissue and freezing at the Royal Women's Hospital. But we were also providing this care for people outside this age range as well. And that's important to note through just, cobbling together funds from the women's, really. So, but the ability to be able to transport tissue and setting this up as a service really was something that we started in 2019, 2020. And the eligibility was for people with cancer, but also for other medical conditions who are, for example, undergoing gonadotoxic treatment, or for gender affirming care also. So from 2019 to 24, so over those 5 years, the NOTS program supported people across Australia with approximately 140 plus referrals and over 20 to, I think, even 30 inquiries, and ultimately the preservation of tissue and storage for 98 cases. And you can see the breakdown there by states. South Australia, New South Wales and Victoria very much contributing, having the lion's share of numbers there, with Queensland, Tasmania, Western Australia being far smaller in terms of the referrals that we get. And looking at it from the perspective of ovarian versus testicular tissue, ovarian tissue was the bulk of the service. This is where, the prepubertal ovarian tissue has resulted in births worldwide. There's been over 2 or even now over 300 births from adult ovarian tissue that has subsequently grafted and resulted in the births of at least one child, in some cases children. So an established, no longer experimental service with ovarian tissue, but considered more innovative. While testicular tissue is still experimental, there has not been a human birth that has resulted from sorry, I've just unmuted myself. And the cases, 87 versus 11 cases, which represented about 11% of the service for testicular tissue. Next slide, Joy. When we look at the breakdown as percentage of cases by childhood diagnosis, we can see that rhabdomyosarcoma and the hematological malignancies such as leukemia, lymphomas, making up a large percentage of our cancer population, and other, you can see non-cancer diagnoses such as autoimmune conditions, anemia requiring bone marrow transplant, but also gender affirming care making up a percentage. But really you can see it's just a bit of a, they're sort of fairly, there's quite a lot of conditions, and there's not a preponderance of one specifically that we see. So what does ovarian tissue cryopreservation involve? So first of all, laparoscopy to remove the ovary or ovarian tissue. In some cases, a whole ovary is removed because of the degree of gonadotoxicity of the expected treatment. For example, radiation would come under that group, where there's not expected to be any residual function in the ovary after completion of treatment. Otherwise, it's usually a part of the ovary that is removed. And when we're thinking about someone very, very young, a young girl, even a baby, the amount of ovarian tissue that we get can be very, very small. The tissue is frozen in slices in the cortex, which are located, the immature eggs or primordial follicles are located in the outer part or in the cortex, and the medulla, the inner part of the ovary, is discarded. Ultimately, when a woman is ready to consider fertility, she's survived her cancer down the track, the intent is to graft the tissue back inside the body, and gentle IVF stimulation can be used to retrieve eggs from that tissue. And the Women's has now performed many cases. We've recently looked at it for a case series, but we're talking about at least 60 cases of ovarian tissue grafting procedures, and we've had around 15 births from this tissue. So that's a fairly successful. It's not quite the same as IVF. It's not anywhere near as in terms of its success rates. However, it's definitely something that has given rise to the to children being born, healthy children. That's an important part of it as well. And there's follow-up that occurs in this population as well, because of we want to make sure that there's no future occurrence of cancer in those grafts. Other fertility preservation methods in general at the women's, but not part of this program, is freezing eggs as well, and ovarian suppression with things like Zoladex. So what about testicular tissue cryopreservation? Similarly, a part of the testes is removed, ideally at the same time as another procedure, which the boy has to undergo anyway for his cancer treatment, such as an insertion of a line. So the tissue is prepared and frozen, and it's the only option for a prepubertal boy for whom spermatogenesis has not commenced. It is experimental, and ongoingly there is investment in research to improve the technology and technique for there to be a human birth, and this is happening all over the world, and including in our centre as well. There has early this year actually a tissue, I think in Belgium, if I'm not mistaken, or the Netherlands, tissue was grafted into an adult male from prepubertal tissue, and we're waiting, and still going to be quite a number of months to see how they get on with creating mature sperm that can be used in the IVF setting. For older boys, they can be mature sperm cryopreserved, or if the ejaculate is unable to be, if the boy is unable to ejaculate or is too sick, then a testicular biopsy can be taken. But this is very different in principle to the prepubertal testicular tissue cryopreservation. Next slide, Joy. So One Day, as is possibly the permanent name of this program, due to the generous donation or philanthropic support of the Children's Cancer Foundation and My Room. Next slide. And we're so excited to be able to create this program and roll it out. The vision is to provide fertility preservation to children and young people with cancer. And it is, as we said, a collaboration between the Royal Women's and these children's cancer charities. The funders have pledged a historic $6.4 million over 5 years, which is quite incredible and inspiring for all of us. And the purpose is to address the impact of cancer treatment on fertility for children and young people. There are 3 streams to the program. 1, education, to provide education, training and support for fertility preservation to both families and health professionals across Australia. Number 2, to expand the transport tissue program to be able to make it relevant and available and logistically possible for more people who need it around Australia. And the 3rd stream being research, to develop technology for safe and successful fertility preservation for children and young people. So the available services are, number 1, coordinating and funding the transport of tissue to the Royal Women's Hospital for where it is taken anywhere in Australia. There's no cost to patients. The freezing of the ovarian and testicular tissue, or processing of this tissue at the Royal Women's Hospital, and also to be available in an advisory support and consultation role for health professionals, be it gynecologists, medical oncologists, haematologists, etc. The eligibility in terms of age group is anyone under 25. It is only for patients diagnosed with cancer or for those previously treated for cancer on a case-by-case basis, and it is from anywhere in Australia. The exclusions are the transportation and freezing of eggs, sperm, or embryos, and those who do not have cancer. So for referring hospital, the approval for patient to proceed must come from the treating clinicians. The procedures are performed at the referring hospital, so the taking of ovarian or testicular tissue. The women's can provide advisory support, as we said earlier, and we're continuing to update and progress with our educational resources for families and health professionals. So how to refer, we hope to make this as easy as possible, and because we've had the NOTS program going now for at least 5 years, I think we've got a system that works quite well. There is a lot of work back and forth. For one case, there can be, as many as 30, 40 emails even to coordinate all of this. So it's can be a Herculean task, but the initial contact is via email or phone number, sending a referral to the women's after that, and then we arrange the tissue collection procedure and transportation via a courier to the women's, and then ultimately the storage of tissue. As part of, not specifically as part of One Day, but part of fertility preservation programs that exist in general is the ART storage funding program, which recently, just go to the next slide, it provides funding for patients with cancer or those requiring pre-implantation genetic testing for monogenic disorders. So the funding for storage of gametes or tissue is actually government funded now, which is a great advance. So it fully funds the cryostorage of eggs, sperm, and embryos for 10 years. So I think I've done pretty well with the time. We've got 5 or so minutes for questions, and we're also going to be recording all the questions we don't get to today as well, so that we can get back to you on an individual basis. Joy, do you want to run the chat?
I'm happy to run the chat, Jenny. Thank you so much. That was amazing to hear about the program, and we're very excited that Women's to be part of this program and to have this opportunity. So thank you again to our philanthropic funders as well. I can see the first hand up is from, and apologies if I pronounce your name incorrectly, Quinn, is that correct?
That's fine, thank you. Jenny, this is great. I just wanted to ask so I work in long-term follow-up late effect survivorship. So previously funded FP has only been available in terms of for adults anyway, in terms of funded storage has only been available for patients who are about to undergo treatment. With the case-by-case consideration of post-treatment patients with this new program, does that mean that any tissue or gametes that are preserved by the program, that their storage will also be funded for the 10 years?
Yeah, so a few different, I think, parts, just to unpick that question a little bit more. And thank you so much for joining, Quint. So glad you could make it today. So if someone has had, for example, a hematological malignancy who has had cancer treatment, so chemotherapy commenced, and then after the initial initiation chemotherapy tissue is taken, it's no different from in terms of storage and funding that way. And in fact, having that tissue, less risk of residual disease and stuff can be actually something beneficial potentially. So that I don't see any issue in terms of taking tissue after chemo has commenced, but specifically we would never take eggs, even if there are immature or partially mature eggs in that tissue. We would never freeze it because of the fact that they've had chemotherapy. But in terms of
say that again. So
I'm not sure if that was part of your initial question, but we wouldn't take eggs from tissue. Like we would freeze the tissue for that patient.
Yeah. Yes.
not eggs from that tissue.
Right. That's, I wasn't so much talking about the acute treatment setting. I meant, say, if I'm seeing someone 10 years post-treatment, and, you know, they're high-risk patients for POI later on, but they're still cycling normally at the time, I would normally refer them for a consultation at the moment. But, you know, in adult patients, and I say up to 25s, in the adult patients, their storage is not funded. So if they come through your program, for example, and they're, I don't know, 17, 18, 19, what happens if, you know, if you are egg harvesting in those patients, they're not about to have treatment, they're quite remote from treatment, is their storage also funded?
So first of all, those patients do not come under the 1-day program funding because we
Right.
don't freeze eggs. So that patient needs egg freezing before they
Right.
run out of eggs.
Okay.
They don't need tissue freezing, and this is not part of what 1-day.
So they
funds.
would just go through the existing channels.
Yeah, through the existing women's
Okay.
fertility
All right. No,
preservation service.
that's useful. Thank you. That's
But
fine.
their storage is now funded through Medicare. So
Okay.
so they don't have to pay for storage actually.
Even many years post-treatment, because, you know, I
For
know
10.
previously it was that they were funded pre-treatment, but not afterwards.
Joy can jump in if I'm wrong. I think you're on mute, Joy. But I believe because it's yeah, it's a good question. I don't know.
Yeah, that's okay. It's not. It's a little bit outside now that I understand the scope of the program.
It's not the
bit
scope
outside
of
your
the
scope. That's fine. Yeah.
Yeah. But yeah, it's a good question. I want to know the answer as well, so I'll find out. Thank you.
Thanks, Jenny.
Quinn, from my understanding, for an IVF patient who has a medical diagnosis, they can still be covered for storage under the public scheme for that the state government brought in. So their storage would be covered regardless.
I was going to say the same thing. I think if a patient has a cycle of IVF pre-cancer, like pre-treatment, they can have a secondary one post recovery. So I think 2 are covered for all women of egg childbearing years.
That makes sense, but I don't think they have to necessarily have one pre-treatment. They can just have a
No,
post,
they don't have to. They could have 2 post, but yeah, they could have 1 pre, 1 post, 2 post, 2 pre.
Yeah.
So just clarifying, Tegan, that includes the storage, not just the stimulation cycle.
That's correct. Yeah.
Okay. Thank you.
And I can see we have a question in the chat. I think that person was next, Jenya. So it's from MM. So in pubertal and adult individuals with the grafted ovarian and testicular tissue produce estrogen and testosterone, or do they require supplementation? Can you see that in the chat?
I can, yeah. I'm just going through it. So in prepubertal and adult individuals, yes. So the idea is, so we don't, let's say if we're talking about ovarian tissue, we don't replace ovarian tissue purely for hormonal supplementation in general, because that can be done in a much simpler way through medications. But yes, that's how we know that the ovarian tissue has started to function, is we can see the hormonal profile changing and the estrogen levels going up and the FSH levels going down.
Thanks,
and that
Jen.
would be the case for testicular tissue as well, we think.
Thank you. And the next person was Lucy. You had a question.
I did. I was just wondering, so you said that this is within the program, it's only for patients who are diagnosed with a cancer. So can I just confirm that counts out any patient who has a non-cancer diagnosis who might be having a bone marrow transplant?
Correct. So a non-cancer diagnosis, even if the treatment for this diagnosis is exactly the same as the cancer treatment, it is not actually funded through this program currently.
Okay. So what would that look like for them if they wanted to pursue testicular tissue that they can't? Or like, would the women still process the tissue or not, but it would be at a private cost?
So yeah, the program doesn't fund it, and I don't know currently the lie of the land for the children's sort of cobbling together funds to fund it. Joy, do you have an opinion on that?
No, I think we're still working through some of that, but we're happy to share any of that information with you, Lucy, and everybody else in this chat as soon as we get further discussion, although David might be able to answer that as well. But I'm very conscious that Margaret has put her hand up, but we can get back to you with that information, Lucy.
Sure.
Just to jump in without showing disrespect to Margaret, we made a decision based upon resourcing in January 2024 to temporarily shut down the prepubertal testicular preservation from the RCH, given that it is experimental, although very hopeful. We've been looking at peripubertal cases on a case-by-case basis and managed to get the job done. And we've been fairly broad in our interpretation of peripubertal. And we've involved Margaret and others when necessary. Without delving further, we hope that this new source of funding can perhaps help the RCH as an important partner, but not the only partner in this national program towards helping us fully resource our oncofertility coordinator. And despite the fact that our hospital has other budgetary constraints, having someone at least to look at each case on its own merits and having the time to do so is a first and necessary step. We generally, whatever hospital we're with, get the job done when we get down to individual cases, as tricky as it can be. What I am concerned about is having too many cooks, and the more heads of department and executive you involve in various hospitals, I would just caution everyone not to bring too many people to the table, because in this era of fiscal constraint, they'll want everything to be done from this nationally funded program, and you can only divide the dollars, even though they're substantial, so far. So I'm just saying, let's work together, collaborate, and be, I'd say, incremental in how we bring everything on board, and keep the locus of control to you guys with us as partners. That's all I'm advocating for.
Thanks, David.
Margaret?
Thank you. Just a comment, I think from the chat, somebody was asking whether the tissues can produce appropriate hormones. I think it's fair to say that for testis tissue, there are multiple xenografts in animals that have been able to produce testosterone, but it remains experimental in humans to date with grafted tissue, although one man has had some tissue put back. It's far too early to see whether it will function. And secondly, for those that are using, it's not my area of expertise, but for those that have put back ovarian tissue, yes, it works for a while, but you get accelerated maturation of the oocytes, and ultimately that tissue fails. So it works for a while, but it's been shown that it does fail after a while. So it's not perfect either, I guess.
Thanks, Margaret. That's absolutely correct. And the literature sort of has a very wide range in terms of duration of ovarian function following grafting. So it can be very short-lived, but there's also been examples of 10 plus years that the tissue has functioned, but it's not forever.
I'm also conscious of time, everyone. I want to really thank you for attending this short notice meeting that we pulled together to tell you about the amazing program that we have called One Day. Just going back to Lucy's question really quickly, because I know we're 1 minute over, is Lucy, the women still do fertility preservation for any patients who have need fertility preservation for other treatments as well outside of cancer, as part of our normal program. But unfortunately, transport at the moment costs the patient or the hospital who we're referring probably needs to pay for that. But we still do preserve that tissue for patients who don't have cancer at the moment, and that's still a national program that we're running. We're trying to see if we can get somebody else to fund the transport costs so patients are not out of pocket.
Okay, that's just a good one for us to discuss, I think, separately as well, because that's a big proportion of our patients that would likely be candidates for this procedure.
And whereabouts are you, Lucy? Where are you from?
The Royal Children's. I'm the Oncofertility CNC at the Royal Children's.
Of course, Lucy. I think I met you a few weeks ago. So.
Yeah.
thank you so much, everyone. We've got this meeting recorded, so we'll share the recording to you, but please spread the word. Our aim is to get 1,000 children through this program in the next 5 years across the whole country, and that's what we're aiming. So we're aiming for 100 children this year, increasing to 200, 250. Thanks, everyone. And Ginia, again, thank you very much.
Thank you, everyone, for joining.